Okay. Good evening, everybody. I am Dr. Professor PC Manoria, Director, Manoria Heart and Critical Care Hospital, Bhopal. I'm also past President, Cardiological Society of India, and past President, Association of Physicians of India. The topic for today is war against heart failure, the new weapons in the armory. The statistics for heart failure are horrifying throughout the globe. The topic for today is war against the statistics for heart failure are horrifying throughout the globe. In the Indian context, we have about 8 to 10 million patients with heart failure. That is about 1% of the adult populations. What is very, very distressing is India has a relatively young population of heart failure. About 22% are below the age of 30 years and 14.9% above the age of 50 years. The post-hospital admission mortality is also high, 20 to 30%. Medication adherence ranges from 25 to 50%. And what is very, very distressing is the incidence of diabetes in heart failure in the Trivandrum Heart Failure Registry is to the tune of 50%, to be accurate, 54.9%, which means half of the patients of heart failure are diabetics. What is also very important to understand is that heart failure, once sets in, runs a malignant progression with a very high morbidity and mortality. The 5-year mortality in heart failure is to the tune of 50%, a figure higher than most of the malignant lesions. Why progression in heart failure continues unabated? There are several reasons. Firstly, even in patients with stable heart failure, myocardial apoptosis continues unabated, which can be seen as elevations, persistent low-level elevations of troponin C, and cardiac function may deteriorate silently, and the patient may get admitted with heart failure. 1 in 4 patients with heart failure with reduced ejection fraction with mild symptoms die or is hospitalized within 3 years. In 1 in 4 patients of HFrEF, the first manifestation is worsening of heart failure or sudden death. All of us know heart failure is also a very bad arrhythmogenic potential, and you can see sudden cardiac death, which occurs unexpectedly in 66% in class 2 and 33% in class 4 patient, which means as the heart failure progresses, the probability of patient dying from sudden cardiac death decreases. And therefore, chronic heart failure should never be considered a stable disease. It has always malignant progression. Pharmacotherapy, which we utilize in our day-to-day therapy, only blunts this malignant progression and does not arrest it. When we look at the evolution of therapies for patients with heart failure, we have the pre-sacubitril valsartan era from 1980 to 2014. Prior to the 1980s, the treatment of heart failure was mainly non-pharmacological. We had only digoxin and diuretics. 1980s was a hemodynamic decade. We have vasodilators and inotropes. Both the drugs, they were useful, but they did not decrease the mortality of heart failure. 90s was a neurohormonal decade with RAS blockers and beta blockers. Both these drugs are very useful in the treatment of heart failure with reduced ejection fraction, and both of them decreases mortality. 2000, we had the device era, ICD, CRT, LVAD, and MRAs were also approved for heart failure in 2003. And 2010 onwards kicked off the cellular era with cell therapy and gene therapy, which is still in the process of evolution. Sacubitril/valsartan era erupted in 2014 after the paradigm HF trial, which was a historical trial, and following this, ARNI, which is sacubitril/valsartan, was approved for clinical use in HFrEF in 2016, and the Pioneer HF trial in 2019, it was approved for acute ADHF also. So we have 4 pillars of heart failure with reduced ejection fraction: ACE/ARB, beta blockers, MRAs, and ARNI. 2019 initiated dawn of a new era with Dapa-HF trial being presented. SGLT2 inhibitors, including Dapa, as you know, all of them were approved for decreasing hospitalization for heart failure in diabetics by all guidelines. But after the Dapa-HF trial, it was approved for heart failure, reduced ejection fraction treatment, both for diabetics as well as non-diabetic. So now at the present state of time, we have 5 pillars for heart failure treatment, and Dapa was the 5th pillar for treatment of HFrEF. Sacubitril/valsartan and Dapa is the first SGLT2 inhibitor which has smashed the boundary between diabetics and non-diabetics. And Dapa has opened a new pathway of heart failure management. The drug was approved for the first time in 2019 itself by the Canadian Cardiovascular Society and by AACIO in 2020, and is also approved by the ESC guidelines. Rather, it is globally approved. The symptoms of heart failure for a layman are cough, shortness of breath, which is more in lying down, we termed as orthopnea, distension of abdomen, tiredness, and swelling over legs. From the point of view of management, we categorize heart failure into 3 subsets. Heart failure with reduced ejection fraction, where the ejection fraction is less than 40%. Heart failure with preserved ejection fraction, where the ejection fraction is more than 50%. And we have a heart failure with mid-range ejection, where the ejection fraction is between 40 to 49%. Now, the heart failure has been categorized into 4 stages. Stage 1 heart failure is when the patient has only risk factor for heart failure, but no signs and symptoms of heart failure. In stage 2, he has a structural heart disease, but no symptoms or signs of heart failure. This classification is particularly designed in mind that prevention of heart failure can be executed in stage A and B. Stage C, the patient starts getting symptoms, and stage D is refractory heart failure, which requires special treatment. And therefore, prevention should be the first goal in our management of patients of heart failure. Another thing we must understand very carefully is every hospitalization, every rehospitalization for heart failure takes the patient closer to death. So if a drug in question is able to prevent hospitalization or delay hospitalization, this is indeed a great achievement. Now, what are our goals of management of chronic heart failure? Relief of symptoms, which should improve the functional capacity and the quality of life, reducing mortality and reversing the slowing the progress of structural abnormality of left ventricle, which we term as remodeling. So our aim is reverse remodeling. Now, this is the landmark Dapa-HF trial. As you can see, 4,700 patients, HFrEF, diabetics as well as non-diabetics, ejection fraction less than 40%, elevated serum markers, EGFR more than 30, and all patients received the standard of HFrEF treatment. The primary endpoint of the study was time to first occurrence of any of the components of composite, that is cardiovascular death, hospitalization for heart failure, or an urgent HF visit. This shows the baseline characteristics, and you can see all grades of heart failure are included, 2, 3, 4. The ejection fraction mean is 31%. Serum markers are elevated. NT-proBNP 1,428. Systolic blood pressure reasonable. Ischemic as well as non-ischemic etiology were included in this. And the EGFR, as you can see, 66. And both diabetics and non-diabetics were included in the trial. Most of these patients were on standard care of therapy. In vast majority of patients, you can see ACE or ARB 94%, beta blockers 96%, MRA 70%. So most of these patients were receiving optimum therapy, and DAPA was tried on top of the standard care. And you can see the primary endpoint, which is a composite of cardiovascular death or hospitalization for heart failure or an urgent HF visit. There was a statistically significant reduction of 26%. And NNT, as you can see, is only 21 within a period of 18 months. When we look at the worsening of heart failure event, again, you can see there is a 30% reduction in this parameter. And when we look at cardiovascular death, again, you can see statistically significant 18% risk reduction in cardiovascular death. When we look at the subgroups, you can see NYHA class 2 as well as 3 benefited. The benefit was more in NYHA class 2. Prior hospitalization or no hospitalization, both subgroups benefited, but those who had prior hospitalization, they benefited more. Ischemic or non-ischemic does not matter. And whether you're a diabetic or a non-diabetic, the benefit was there. So the first big message from Dapa-HF trial was that dapagliflozin was useful both in diabetic patients as well as non-diabetic patients with HFrEF. In other words, DAPA has smashed the boundary between diabetic heart failure and non-diabetic failure. And this is the first anti-diabetic medication which has been approved for treatment of HFrEF in a diabetic patients besides non-diabetic. What was very interesting is that it also showed benefit on top of ARNI, and the benefit was nearly same whether you were receiving ARNI or whether you were not receiving ARNI. And it has opened a new pathway for heart failure. All drugs which decrease mortality in heart failure act through the neurohormonal blockade. This drug does not act through the neurohormonal blockade. It has a separate pathway or treatment of heart failure. And it is poised to change the definition of refractory heart failure. Whenever we have a patient of refractory heart failure, reduced ejection fraction, before labeling it as refractory, we always ask whether you have taken ARNI or not. If you have not taken ARNI, go and take ARNI and come back. Now we will be asking, have you taken DAPA or not? If not, please go and take DAPA and then come back. And many patients may improve without a device therapy. So it is poised to change the definition of refractory heart failure. It is poised to postpone deviant therapy like CRT, LVAD, or even cardiac transplantation. When we look at the secondary endpoint of cardiovascular death and hospitalization for heart failure, there's a 25% reduction. And when we look at total HHF and CV death, again, you can see a 25% risk reduction. And all-cause mortality also, as you can see, there's a 17% reduction in the all-cause mortality. Dapa-HF also decreased NT-proBNP level But what was very curious is the subsets which benefited most from DAPA were the subset which has least elevation of NT-proBNP, clearly indicating that DAPA has an independent pathway of benefiting patients of heart failure, and which is indeed very, very exciting. When we look at the safety of dapagliflozin, you can see it is a very safe molecule. Most of the adverse effects are just like a placebo, so you can take it very safely. For example, if you look at the volume depletion, there is no statistically significant change whether you are on a DAPA or whether you are on a placebo. So volume depletion may occur, but is not seen in significant number of patients. Just as when we look at urinary tract and genital infections, again, you can see there is not much difference between the group receiving dapagliflozin and the group receiving placebo. So what Dapa-HF trial has taught us? It has passed on revolutionary message. This is the first trial of an SGLT2 inhibitor which has shown benefit on top of standard care treatment, which means beta blockers, AC inhibitors, or ARBs, MRAs, and even ARNI. This is the first trial which has shown benefit in diabetic as well as non-diabetics. The cardiovascular death, the hospitalization for heart failure, all-cause mortality, all were statistically decreased. It has shown benefit on top of ARNI and is a safe molecule and can be used in our day-to-day practice. When we look at the mechanism of inhibition or the mechanism of benefit in heart failure, there are multiple benefits, as you can see on the slide. It can produce natriuresis, it improves the cardiac bioenergetics. Mild persistent ketonemia, as we know, is an energy efficient superfuel. Reduction in interstitial edema, which I'll explain further. Inhibition of the sodium hydroxide exchange, which is an important modality for remodeling, and it also reduces preload and afterload and reduction in the LV wall stress, and it also improves renal and cardiac function. And this explains the mechanism of renal benefits of DAPA in patients with heart failure, because heart failure and kidney failure go hand in hand. If heart failure worsens, kidney failure will worsen. If kidney failure worsens, heart failure will worsen. And one of the very important mechanisms why DAPA provides nephroprotection is that it produces efferent arteriolar constriction, so that the intraglomerular pressure is reduced. And besides this, it also decreases blood pressure, plasma volume, afterload, preload, LV wall stress, and it also produces glycolysis. This slide shows the other mechanisms which are involved in its beneficial effects. The kidney mechanism I've already talked of. There's also improvement in the myocardial bioenergetics. And I'm already talking to you that blocking NHE1 is beneficial in patients with heart failure, because if any EHE1 is increased, it produces cardiac remodeling, which is detrimental to patients of heart failure. Now, how does SGLT2 inhibitors differ from diuretics? As we know, if you use diuretics, they not only decrease the intravascular volume, but they also decrease the interstitial volume. But unlike diuretics, SGLT2 inhibitors, they decrease interstitial volume, which is of immense importance for cardiac function as well as renal function. So this is another one of the very important unique features of SGLT2 inhibitors. And when we talk of the utility of dapagliflozin in the continuum of heart failure in patients with diabetics, you can see DAPA is useful throughout the continuum of heart failure. You can use it in stage 1 when patient has only risk factors for diabetes. And as you can see, it imparts 3 beneficial effects in stage 1. The HbA1c is decreased, the body weight is decreased, the systolic blood pressure. You can also use in stage 2 heart failure when there is cardiac remodeling has set in, although the patient may be asymptomatic, and is obviously used in stage 3 and 4, where it decreases hospitalization for heart failure, cardiovascular death, and all-cause mortality. Now, this is the AMPA heart study, which was carried out with empagliflozin, and this shows positive results. It showed a meaningful reduction in the left volume mass index, clearly indicating that SGLT2 inhibitors also produce reverse remodeling. What we were talking about for last 30 minutes is all about heart failure with reduced ejection fraction. The second category of heart failure is heart failure with preserved ejection fraction, and till date, all trials in heart failure with preserved ejection fraction has been flop trials. No trial has been positive in HFpEF, but there is expectation and there's a lot of hope that SGLT2 inhibitors may show positive results in HFpEF. And there are several reasons for this. The first reason is in the declaratory 58, some patients of HFpEF are included and they have shown beneficial results. The second reason is that it decreases interstitial edema, and experimental work has shown that if the interstitial edema is decreased, even in absence of regression of left ventricular myocardial function, the heart is able to relax better, and this may be the other reason why we believe that these trials may come out to be positive in HFpEF. And the third reason is DAPA acts through a new pathway for heart failure. All drugs which have failed in HFpEF act through the neurohormonal pathway. So based on this hypothesis, there's also an hope, because this pathway has never been tested in HFpEF, it may come out to be positive. Several trials with various SGLT2 inhibitors are ongoing. The DELIVER trial with DAPA. AMPA is also having trials with heart failure with preserved ejection fraction, and we are keenly awaiting the results of these trials. SGLT2 inhibitor, as you can see, DAPA has done the formidable task of improving cardiovascular outcome in HFrEF on top of all 4 pillars of treatment. The first pillar was ACEOAI, beta blockers, second, MRAs, third, and ARNI. And when you use DAPA, it has shown benefit on top of all these 4 pillars of heart failure. And DAPA has become the 5th pillar of heart failure in today's scenario. And it is therefore a new weapon in our army to fight the devil of heart failure. All of us know SGLT2 inhibitors continue to surprise us. DAPA is the first SGLT2 inhibitor to show benefit in HFrEF in non-diabetics as well as diabetic patients. We are keenly awaiting the results of SGLT2 inhibitors in HFpEF, that is the DELIVER trial. Learning with SGLT2 inhibitor continues unabated, and we are still learning. The Dapa-CKD trial has also been prematurely terminated because of immense benefit, and it has shown great benefit again in diabetics as well as non-diabetic patients. And what is also very interesting is that the new analysis from Dapa-HF has shown that 32% reduced risk of new onset diabetes, and therefore this is again a new feather in the cap of Dapa. The widespread benefits of SGLT2 inhibitors have created feeling of possessiveness amongst the super specialists. SGLT2 inhibitor was introduced as an anti-diabetic medication, and therefore the diabetologists think it is a drug of diabetologists and belong to their specialty. SGLT2 inhibitors, Dapa has shown beneficial effect in HFrEF, both in diabetics and non-diabetic patients, and therefore the cardiologists feel that it is their drug and it is the drug of the cardiologist. And its benefit in renal protection is unprecedented. It has changed the trajectory of CKD, and it has slowed down the decline in eGFR by almost 40 to 45%, and it is a boon for patients of CKD, and the nephrologists are very keen to use this drug, and therefore they believe this is a drug of the nephrologist. But what is the solution to this? Our view is it is not a drug of any specialty, but it is a drug for the welfare of the patient, and that is the appropriate class where this drug should be put in. Thank you very much for your kind attention. Yes, right. Not yet. I removed. Yes. The first question is, can Dapa be used in patients who are already receiving ARNI for HFrEF? This is a question from Steffi. Hello? Heart failure. Steffi D'Souza. I think the Dapa-HF very clearly shown that even if the patient is on ARNI, it has shown incremental benefit. So if you're already taking ARNI, you will have an incremental benefit on top of ARNI. And the reason is it acts through a different pathway than the other hormonal blockers. The confidence interval was also very good. Only some 10 or 11% was more than that. And therefore, when we are using Dapa in these patients, we will try to pick up those patients who have a little higher confidence interval than 1. Is Dapa associated with hyperkalemia or decrease in blood pressure? From Dr. Karamveer Agrawal. It is ARNI which is associated with hyperkalemia and decrease in blood pressure. The effect on Dapa on hyperkalemia or blood pressure is negligible. There may be mild reduction in blood pressure, but usually it does not come in way of initiating Dapa in patients with HFrEF. Dr. Thapar, what are the results of drug therapy in heart failure with preserved ejection fraction? I've already told you no therapy till date has shown positive results in this subset of patients, that is heart failure with preserved ejection fraction. We have lots of hope from Dapa for several reasons I've already pointed out. The first reason is it acts through a new pathway of heart failure, which has never been tested in patients with HFrEF. Secondly, some of the patients in declared TB58 have HFrEF, and these patients who were given DAPA, they have shown beneficial effect. And the third reason I've told you, there is now experimental data that when we use SGLT2 inhibitors, due to decrease in the interstitial fluid, the myocardial fibers are able to relax better. There's improvement in the diastolic function. So these are the reasons that perhaps trials of DAPA in HFpEF may come out to be positive. But this is the hope. The reality will come when DELIVER trial or EMPA trial with HFpEF will be released. But there's lots of hope for these two reasons, just not a presumption. There are reasons behind it why DAPA may produce positive results. There's a question from Kritika Khanna. Which MRA you prefer in patients of heart failure with a tendency for hyperkalemia? Now, you must always remember that heart failure and kidney failure are always coexisting. If heart failure increases, kidney failure will increase and vice versa. So these patients, they have a tendency for hyperkalemia. And if hyperkalemia occurs, there's problem in using drugs for heart failure like MRAs or drugs for heart failure like ARNI. So if there is an anticipation that patient will develop hyperkalemia, our choice for MRA is not aldactone, but eplerenone. And the reason is the metabolites of eplerenone disappear in 12 to 24 hours, unlike aldactone, which takes 4, 5, or even 6 hours to disappear, because eplerenone is a short-acting drug. So this is the reason, if there's potential for hyperkalemia, we would like to prefer eplerenone rather than this, so that we can easily stop the drug and reverse the hyperkalemic drugs, modify the dose, or you can use resins or other newer drugs like petromyr to combat hyperkalemia. But at attempts in heart failure, even there is hyperkalemia, we will treat hyperkalemia and try to use all these drugs, although they have potential for, like the MRAs, like ARNI, we'll always try to use drugs and try to minimize hyperkalemia with several drugs and dietetic restrictions, and if required, even dialysis. Yes, Meera, you have asked a very interesting question. Is it possible to have heart failure without patient being aware of it? Very interesting. Stage A of heart failure, no symptoms and signs. Stage B of heart failure, no symptoms and signs. I think most of the non-communicable diseases, the problem is they do not produce symptoms. You may be severely diabetic type 2, you may not have symptoms. You may have severe hypertension, you may not have symptoms. And the same applies for heart failure. You can be in stage 1 and 2 and may not be aware that you are suffering from heart failure. That's why I say prevention is very important, and prevention can be done in stage A and stage B heart failure, which means if you have a risk factor of heart failure, treat it, you will not develop heart failure. If there is a structural remodeling in heart failure, try to improve it by drugs, RAS blockers, ARNI, and even the SGLT2 inhibitor. But this is true. This is Mr. Bhaskar. Can DAPA be used in patients of heart failure with diabetes? Certainly, we have now documented evidence that DAPA benefits patients of heart failure, whether you are diabetic or non-diabetic. The benefit is similar. So diabetes does not come in way of use in heart failure. Certainly, you can use it. And there's no hypoglycemia in patients when you are using in non-diabetic patients, because that is often a scare. This I have already replied. This is again a very interesting question from Dr. Nimisha Sinha. Up to what level of eGFR you can use ARNI in heart failure? The usual cutoff point, as we said, is 30. But whenever a patient has a GFR in the borderline, now trials have been initiated even up to 30. Our attempt is first to decongest the heart by drugs or modalities which do not affect the potassium levels or eGFR. For example, if you have a patient of heart failure CKD, we'll try to decongest with use of say nitrates plus hydrogen combination, or use inotropes, or even vasodilators. And once the cardiac output improves, we can initiate drugs. And when these drugs are initiated, you can see when the cardiac output improves, the eGFR also improves, because heart failure and kidney failure are vicious circle. They are very closely interconnected. So our aim is always to use ARNI in patient with heart failure, so that this is the way we try to initiate ARNI after we have decongested the heart failure. We have improved the cardiac output. This will also improve the renal functions, and even the eGFR may come down. And when you add ARNI, the eGFR after an initial increment will go down further, and then it will remain stable. And those who are working in the nephrology department, they use even in dialysis patient, because there's no problem. They can dialyze the patient in the event of hyperkalemia. Hyperkalemia is a threat when we are using ARNI in patient with CKD. But in nephrology units is used in patients with dialysis, because it is the important drug which prevents cardiovascular death. Most of the patients of CKD will die of a cardiovascular death, and ARNI is one drug which decreases cardiovascular death. So that is the reason we always want ARNI to be used in patients with CKD, always taking precautions of hyperkalemia and acute kidney injury. This is Dr. Agrawal. What is the significance of SGLT2 inhibitors in relation to BNP and anti-proBNP? Now, if you are trying to assess heart failure in a patient who is on ARNI, never use BNP, because ARNI increases BNP level. So patient in ARNI, please use anti-proBNP. That is, ARNI is not reliable. Currently, biomarkers are used for diagnosis of heart failure, for judging the prognosis, for initiating treatment, for deciding the optimum time of discharge. So they are used in all stages of heart failure. Serum markers are very useful in patients with heart failure. They help us a lot. Sometimes when there is a problem in diagnosis of HFpEF, particularly when echocardiography is not available, this may be utilized to differentiate whether the patient is suffering from heart failure or from a lung disease. So this has immense value. Serum markers are good in heart failure. Dr. Srivastav, when do you initiate ARNI and when do you initiate SGLT2 Dapa in non-diabetic patients with heart failure? Now, one thing you must always understand, that in heart failure, combination therapy is the rule. You must try to use all mortality reducing drugs, because each one of them has an incremental benefit. So if it's a non-diabetic patient, we may, in some circumstances, decide to use Dapa first or ARNI first. Now, if there's a problem of eGFR, suppose eGFR is borderline, and there is a tendency for hyperkalemia or borderline hyperkalemia, we would like to initiate Dapa because it doesn't affect. And when the cardiac function improves, we like to initiate ARNI. If blood pressure is not a problem, so blood pressure is not a problem, or patient is not symptomatic from even borderline range, maybe 90/60, then we will initiate ARNI also. So when to initiate ARNI, when to initiate Dapa may differ. The sequence of initiation may differ, but ultimately our aim is to have all these drugs on the board, because all of them have incremental benefit, and heart failure has a malignant progression. The 5-year mortality in diabetic heart failure is 85%, in non-diabetic is 50%. So combination therapy, all drugs to be initiated as and when possible. This is Dr. Bhatia. What are the most common causes of heart failure? In our day-to-day practice, we see heart failure due to diabetes, heart failure due to hypertension, coronary artery disease, cardiomyopathies. These are some of the important causes of heart failure. how do you monitor heart failure at home? In the Western countries, there are various monitoring devices, but Indian countries, their use is meager. Then there are telephonic consultations and consultations on the internet. But India, these devices are not in practice at the present state of time, but I'm sure they will be utilized. The whole idea of these is try to find out whether the patient is gaining weight. Some of the device even tell about the pulmonary capillary pressure, so you can increase the dose of diuretic. So just inform the treating physician what is happening to the patient, and drugs can be initiated early enough so that the patient does not deteriorate and does not get hospitalized. They are useful in preventing hospitalization for heart failure by initiating treatment in early phase. This is Dr. Agrawal. What is the role of SGLT2 inhibitors in CKD without diabetes and heart failure? I think the DAPA CKD trial has been terminated prematurely, and this has shown benefit even in non-diabetic CKD. Any kidney disease which is proteinuric will have immense benefit. If proteinuria is not there, the magnitude of benefit is much small. But whether it is a non-diabetic proteinuric kidney disease or a diabetic proteinuric kidney disease, the benefit is always there. So it is proteinuria which decide, because these drugs, they decrease the intraglomerular pressure. Once you decrease intraglomerular pressure, then the proteinuria decreases. And all of us know if there's proteinuria hastens the progress of CKD. So non-diabetic kidney disease, the DAPA CKD trial has been positive. Yeah. This again is a very good question. What is asymptomatic left ventricular dysfunction? Now, as I already told you, there are 4 stages of heart failure. Stage A, you have only risk factor. You get your echocardiogram normal. Stage B, you have changes in your heart, but you are asymptomatic. And if you detect heart failure at this stage, use drugs like beta blockers, AC inhibitors, and other drugs, you can postpone the deterioration in left ventricular dysfunction. So recognition of asymptomatic left ventricular systolic dysfunction is very important, and patient must be strictly emphasized that you have to use drug, otherwise it will hasten death. When you start initiating these drugs, which I've told you, in the symptomatic phase, the longevity of life cannot be increased to a greater extent compared when you initiate in the asymptomatic. So initiation of asymptomatic phase with all these drugs will increase your longevity of life to a much greater, and they should be initiated if you have asymptomatic left ventricular systolic dysfunction. Beta blockers, ARNI, and now we have DAPA and all these drugs. They will immensely change your prognosis in the long run. What is the difference between acute and chronic heart failure? Chronic heart failure means all these hemodynamic process and symptoms occur gradually. Acute means the patient suddenly get admitted in acute decompensated heart failure. And besides decongestive therapy and other modalities, now we have another new drug, ARNI, which has seen that once the hemodynamic stability is achieved, which means the patient is no longer requiring inotrope, no longer requiring intravenous diuretics, his blood pressure remains stable for 6 to 12 or 24 hours, you can initiate ARNI also. It is seen that if ARNI is initiated in hospitalization, the compliance is better, the magnitude of benefit is also better. So acute heart failure, these drugs so also applies for SGLT2 inhibitor. These drugs are not to be used in the acute decompensation stage. After the hemodynamics are stabilized, these drugs are very useful, and you can initiate after 3-4 days. And it is better to initiate in the hospital where the hemodynamics have been stabilized rather than patient goes, because adherence is less and patient may not take with the drug. And the magnitude of benefit is also more, it is seen when you initiate during the hospitalization. This is from Dr. Bhavna. What is the role of BNP and anti-BNP? Now, as I have already told that these markers are commonly utilized in our day-to-day practice of heart failure. If heart failure is in doubt, particularly heart failure with preserved ejection fraction, particularly if you are not having access to echocardiography, it may at times be difficult whether the shortness of breath with the patient is due to a heart failure, due to a lung disease or some other disease. And if the levels are increased, it will go in favor of heart failure with preserved ejection fraction. The diagnosis of heart failure with reduced ejection fraction is usually straightforward because it is easier to diagnose by the clinical signs, unlike HFpEF, which has a lot of mimics. Secondly, they are used to assess the response to treatment. They are used to assess the appropriateness of the timing of discharge, and in the long-term follow-up, they are again useful. So they have multiple uses. They are useful throughout the natural history of heart failure. If the patient is an ARNI, please do not use BNP because BNP is increased by ARNI and you will have wrong information that your heart failure is worsening due to increase in BNP levels. You should use anti-BR, anti-pro-BNP if the patient is on ARNI. That you must always remember. Now, ICD is very useful in heart failure with reduced ejection fraction. If your ejection fraction is less than 35%, this becomes an indication for ICD, say following myocardial infarction. But because this is a costly device, it is not used in large numbers in the Indian context, but it should be used very useful for secondary prevention. Secondary prevention means patient is already in an episode of ventricular tachycardia and ventricular fibrillation. This is an absolute indication. Those patients who have left ventricular dysfunction less than 35, this is also an important indication. But the patient agreeing for an ICD, many times there are problems because patient has not suffered from an episode of, but it should be used if there are no financial constraint. DAPA and ARNI have delayed the initiation of device therapy because both these drugs, if you remember, ARNI also decreases sudden cardiac death. DAPA also postpones the development of hospitalization for heart failure. So both these drugs are postponing device therapy, particularly those which improve heart failure, say CRT or LVAD or even cardiac transplantation. It has been seen in the ARNI trial that the use of device therapy will also decrease. It also reflected in the ICD. This is Dr. Murthy. Can we start DAPA without using ARNI? I already told you the sequence of initiation of DAPA, ARNI, or that depends on the subset of patient. There's no hard and fast rule that you have to use ARNI first, you have to use DAPA later on, you have to use DAPA first or ARNI. Depending on the subset, for example, if your blood pressure is not a problem, your EGFR is not a problem, you can initiate ARNI. If there's hyperkalemia, there's a borderline GFR, there's a problem of hypotension or borderline hypertension, you can initiate DAPA. So sequence of initiation may be different, but our attempts to have all these drugs on the board. You can, if you're a diabetic patient, you can initiate DAPA, stage A, B, C, D, all stages it is useful. Even a stage you can initiate DAPA. Ventricular assist device is a device which is utilized in patients with refractory heart failure. It is either utilized as a bridge to transplant. Those patients of heart failure who are not responding to all possible treatments continue to remain in heart failure. And if you do echocardiography, they show persistent restrictive function. These are the candidates for left ventricular assist devices. So many times the donor for heart transplant is not available. So LVAD is used as a bridge to transplant. The patient is on LVAD, and when the donor comes, he is put on a transplant device. The second indication currently is they are also used as destination therapy. because with advancement and refinements in the techniques of LVAD, this is now also being used as destination therapy, and this facility is also available in India, and patients survive for a couple of years even when it is used as destination therapy. And sometimes if the patient has a reversible cause of heart failure, say a cardiomyopathy, and if it shows regression reversal, then it may be removed from the patient. But otherwise, these are the two principal uses, either as a destination therapy or as a bridge to transplant. Bridge to recovery, as we said, you are lucky if your heart failure was having a, say, viral myocarditis, it recovers or whatever may be, then it may be used as a bridge to recovery also. Or, okay. CRT, cardiac resynchronization therapy, Dr. Krishna. Now, this is a therapy which is being utilized for those patients who have complete left bundle branch block and are in heart failure with reduced ejection fraction. It resynchronizes the ventricle. There are two pacing leads. One is placed in the right atrium, other is placed in the left ventricle and at an appropriate site. And when this device works, it resynchronizes the ventricle, and the cardiac output improves, the mitral regurgitation decrease. That is called CRT, resynchronization therapy. LBB makes the ventricle desynchronous. The prognosis of patients of heart failure, this is from Dr. Maheshwari. As already said, heart failure, once sets in, runs a malignant progression with a very high morbidity and mortality. If you are a diabetic, the 5-year survival is only 15%. If you are a non-diabetic, the 5-year survival is 50%. But if you initiate these newer therapies, it is seen that you may have an improvement in the projected survival by 5 to 6 years, so that if you use all these therapies, say at the age of 55 years, the projected survival is improved by 5 to 6 years. So optimizing management of heart failure with all these therapies will improve the long-term prognosis. And as we said, never de-escalate therapy in heart failure, even if the symptoms are less. The treatment of heart failure is escalation, escalation, escalation. If you de-escalate, the patient will suddenly deteriorate and may even collapse. So there we are now powered to improve the prognosis of heart failure in the current era due to these new drugs, and even devices play a very important role. This is from Dr. Deepthi. What causes increase in the left ventricular chamber stiffness in the pathophysiology? Now, whenever you have this increased stiffness, it produces a diastolic heart failure, or we call it as HFpEF. The heart failure is primarily because the ventricle is not able to relax. This may be due to left ventricular hypertrophy due to any cause. Commonly, it is hypertension. You may have an hypertrophic cardiomyopathy, or there may be infiltrative cardiomyopathy like amyloidosis. And there are many other causes. So if the heart or the left ventricle is become stiff due to infiltration, due to hypertrophy, due to fibrosis, it fails to relax, and this results in heart failure with preserved ejection fraction. Because when the blood comes, it cannot accommodate, so it produces pulmonary edema, it cannot go forward, so it accumulates. So that is HFpEF. This is again Dr. Agarwal. What is the role of hydrology and nitrate when these are used in heart failure? As we said, if your renal function is normal, we always try to use RAS blockers, including ARNI also. But we have lots of patients of CKD associated with heart failure, where the eGFR is 30 or maybe less than this, where if you use RAS blockers, if you use ARNI, your eGFR may deteriorate. You may also have an acute kidney injury. To avoid acute kidney injury, this is a serious complication. Never forget, if you have an acute kidney injury, whatever glomeruli are affected, they are lost forever. Recovery from acute injury does not mean that the glomeruli which were affected have regained. They will never regain. So acute kidney. So to prevent this acute kidney injury, we use drugs like hydrolazine and nitrates, which decongest the heart. Hydrogen decreases afterload, nitrogen decreases preload predominantly. So when you use these patients in patients with CKD, the heart stroke volume and cardiac output improves. Once this improves, the kidney blood flow also increases, and the EF and GFR may also improve, and then you can initiate these RAS blockers in ARNI. So that is the use of hydrogen and nitrates, and that it's also used in black patients where RAS blockers do not produce favorable effects, but that is not applicable to me. Is there any study, this is from Dr. Murthy, which documents ICD is postponed? Now, Dapa-HF is a recent trial. No study has been done. Ideally, I think in the present era of ARNI and Dapa, one should revise the indications of CRT and indications of ICD. But I don't think this will be done. But it is quite logical that you may delay implantation of these devices, particularly devices which improve left ventricular dysfunction. ICD, we know ARNI, the use of ARNI in the paradigm trial did not show any increase in the use of ICD compared to the placebo arm. So ICD were not increased in the ARNI trial, paradigm trial. But we do not have any documented trial. This is from Dr. Ras. What should I do if the symptoms suddenly get worse? You should hospitalize. You are mostly suffering from acute decompensated heart failure and be under the supervision of a cardiologist. This is an emergency. You must get hospitalized and they will treat according to the cause of heart failure and the features. But you must get, if the symptoms suddenly worse, please do not remain at home. The mortality benefit and the symptomatic benefit is much higher if you're in the hospital rather than at home. Must get hospitalized. This is the last. Yeah. I'm sure you had enjoyed the information given by me on heart failure with reduced ejection fraction. All of us know currently we have 5 pillars of heart failure. ACE, ARB, we have beta blockers, we have MRAs, we have ARNI, and the new pillar is dapagliflozin. But for heart failure with preserved ejection fraction, we are still in the search of a positive trial, and SGLT2 is creating expectation that we may have a positive trial. The other big message is heart failure, once sets in, runs a malignant progression. Pharmacotherapy can only blood this malignant progression. It does not arrest the malignant progression, and therefore prevention should be the goal. And this is a very important goal. You must stress on prevention of heart failure, because if you become a patient of heart failure, your long-term prognosis is compromised. And as already said, combination therapy should be the rule. When you're treating heart failure, you should become oncologist. Oncology, we have combination therapy. You should use combination therapy, never de-escalate therapy. And if you want to de-escalate therapy, particularly in patients with pericardial cardiomyopathy, you must have a normal ejection fraction and also a normal GLS. Otherwise, never de-escalate therapy. Usually there's resistance. What are the enemies of heart failure? Usually there's resistance from the patient, from the attendant, sometimes even from the physician. Please do not add on drug. My shortness of breath is much better. Don't listen to them. This is the biggest problem in the management of heart failure. You have to sequentially use all drugs, escalate, and use all drugs, because each has an incremental benefit. Suppose you drug A and then you B, incremental benefit, and so on. So multiple combinations should be used, but prevention should be the goal. And as our age is advancing, the longevity is advancing, heart failure is increasing day by day, and the number of heart failure patients are progressively increasing. And with better treatment of coronary artery disease, the patient is surviving long, but all of them ultimately come with heart failure. So heart failure is globally, as well as in the Indian context, is a great problem, and we must declare a war against heart failure. Thank you very much.
It's from the world's best medical minds. You are watching TheRightDoctors.com.